Ladies and gentlemen, you're welcome to our webinar titled COVID-19 Pandemic, Diaspora Ethnic Minorities Perspective. My name is Dr. Peter Julu, your moderator for this webinar today. I'm a specialist autonomic neurophysiologist and a consultant physician with an honorary consultant post with the Bath National Health Trust. And I'm also a senior research fellow with the Queen Mary University, London, and a fellow of the Royal College of Physicians in London. The organizer today and the host of this webinar is the Diaspora Health Strengthening Partnership, DHSP. It's a charitable organization limited by guarantee and is registered in England and Wales. It was formed in 2017 in response to a call from the Health Education England and Global Health Engagement at Health Education England, who they really needed an assistance in strengthening health system in northern Uganda. So DSSP is run by a steering committee and it draws its membership from Ugandans in the United Kingdom and abroad. These are members who have healthcare, administrative, and governance skills. The partnership therefore brings together experience from education, public health, international development, and works with health-based institutions in Uganda and also in the United Kingdom in order to develop and deliver intervention that can strengthen healthcare system, primarily in northern Uganda, but this is scalable. It can be scaled up to the whole of the African regions. Now, the panelists today, we have got one panelist, Dr. Kilama-Oceng. Can you wave your hand? Dr. Kilama is a retired, general practitioner. Dr. Kilama obtained his medical degree from Makerere University in Kampala, Uganda in 1976. He then obtained his membership of the Royal College of Obstetrics and Gynecology in London in 1983, but he went to practice in Saudi Arabia. However, he came back to United Kingdom in 1988, and after a brief practice of obstetrics and gynecology, he decided to go back to basic and became a general practitioner in 1996. Dr. Kilama trained under the Joint Committee on Postgraduate Training for General Practice within the Royal College of General Practice. He retired in 2019, just before COVID-19, conveniently. Ladies and gentlemen, Dr. Kilama, our panelists.
Thank you.
Yes, thank you very much, Dr. Julu, and the presenters for today.
Now,
okay.
Our first presenter today is Dr. Churchill Onen. Dr. Onen is our son, actually, in the diaspora, right in Botswana. He's a senior consultant physician in private practice, affiliated to Life Gaborone Private Hospital. He is a graduate at Makerere University with a postgraduate and initial degree from Makerere University. He is also a fellow of the Royal College of Physicians in London. He was awarded for his distinguished service in medicine. Dr. Onen's experience includes rural health, hospital administration, executive healthcare, civil service, academic and private practice, with a special focus for diabetes and cardiovascular diseases for over 40 years. His experience actually spread over 40 years. He also served as a member of the World Health Federation in the section of epidemiology and prevention. Dr. Onen is a founder and a patron of Diabetes Association of Botswana and was a project manager of the Botswana's pioneering retroviral therapy program. So Dr. Onen is not actually a stranger to new viral illnesses. And by the way, this is the one of the first and most successful antiretroviral rollout program in sub-Saharan Africa. Dr. Onen also had the honor to be the first Black African to give the Lilly Lecture of the Royal College of Physicians, London. He published widely in peer-reviewed medical journals, and he has contributed also to book chapters. Ladies and gentlemen, Dr. Churchill Onen, our first speaker. Dr. Dan, you can come in now. I've stopped sharing.
Thank you. Thank you so much, Dr. Peter Julu, for those kind words of introduction. I believe everyone can hear me.
Yes.
Thank you. Now, it's an honor to have been invited to the Diaspora Health Strengthening Partnership. And like all partnerships, it should take two or more to tangle. And we will tangle this afternoon with two diseases, namely hypertension and diabetes, and what impact they may have on the current COVID-19 pandemic. In the outline, I will talk briefly on hypertension and diabetes as major cardiovascular risk factors and common diseases. I will mention some residual cardiovascular risk associated with diabetes particularly, but also with hypertension. I'll make general conclusions and perhaps give some guiding principles before we go for the questions and answers. From the outset, let me quote Joseph Joubert, 1954-1824. Joseph said, the aim of an argument or a discussion, such as we may have this afternoon, should not be victory, but progress. And we hope to see progress in this session. Now, hypertension, as I said, is central in the cardiovascular continuum of risk factors. It's said to be the first westernized non-communicable diseases that occurs in rapidly urbanizing population, followed by diabetes. On a global scale, in 2015, there were perhaps more than 1 billion human beings with hypertension. That itself may be an underestimate, since not everybody would have had their pressures diagnosed. 75% of those are in middle and low income countries. In Africa, we estimate anywhere upwards of 20 to 30% of the population with hypertension. The regret is that many of the hypertensives are asymptomatic, meaning they don't have any complaints to refer to, and therefore most are unaware. Most do not take sufficient lifestyle changes or do not take their blood pressure lowering medications at all or regularly, or do not achieve blood pressure control, and therefore do not achieve reduction in cardiovascular risk factors. The definition of hypertension, I keep sliding into diabetes. The definition of hypertension depends on which side of the Atlantic you are on. If you look at this slide, maybe three things will strike you. First is that definition depends on the side of the Atlantic, as I said. Secondly, where the blood pressure is measured, whether it is in an office, at a doctor's practice, or at home. And thirdly, the timing of the blood pressure measurement, whether it's a daytime blood pressure or a nighttime blood pressure. Perhaps it's important to stress that, in fact, the method of measurement is also critical, a one-off reading versus ambulatory blood pressure monitoring for 24 hours. Going to the American College of Cardiology, American Heart Association criteria. This was derived in 2017 for the purpose of prevention, detection, evaluation, and management of high blood pressure in adults. It was actually published in 2018 in the Journal of American College of Cardiology. What we see here is that according to these guidelines, the blood pressures in the clinic, the home blood pressure monitoring and daytime blood pressures by ambulatory blood pressure monitoring are identical in defining hypertension. 130 or more systolic pressure greater than or 80 greater than. And that defines hypertension in the Americas. At night, their stringent cutoff is 110/65 or higher. And the 24-hour ambulatory blood pressure would be greater than 125 or 75 millimeters of mercury diastolic or higher. On this side of the Atlantic, the European Society of Cardiology and the European Society of Hypertension in 2018 introduced 140 or higher and 90 or higher as an office blood pressure that could be used for defining hypertension. Whereas the home blood pressure monitoring and the daytime ambulatory blood pressure monitoring are the same, but still somewhat higher by 5 millimeters for both systolic and diastolic readings compared to the American reading. Similarly, the nighttime ambulatory blood pressure cutoff is higher, 120 or greater and 70 or greater. And also the ambulatory blood pressure is higher by 5 millimeters. So it's almost like adding 5 to most of the figures except the clinic blood pressure. We need to be careful that there is a thing called white coat hypertension. Traditionally, many doctors wear white coats. That is not necessarily the issue now, but this is an office blood pressure that is elevated beyond 140, beyond 90, depending on which one is higher, in the doctor's office. Whereas when the individual is outside the doctor's office, the pressures are normal. There's also a thing called the masked hypertension. Masking means when the patient walks into the doctor's office, the pressures are normal. When they get out, there are probably adverse situations out there that raises their blood pressures, whether at home or at work or whatever factors. I need to talk about resistant hypertension only in the context of a treatment that has failed to normalize or control the blood pressure. And this should not be a topic for discussion at the moment. Blood pressure may be primary when the cause is unknown, and that occurs in about 95% of all hypertensives, and secondary in about 5%. Now, we need to clarify that we are talking of systemic arterial blood pressure elevation. And here, HT or hypertension will be synonymous with systolic arterial blood pressure elevation. And the higher value determines the stage of the hypertension. In this slide, normal would be less than 120 systolic, less than 80 diastolic. Elevated pressure is 120 to 129 systolic, with a diastolic less than 80. Stage 1 hypertension would be 130 to 139 diastolic of 80 to 89. And stage 2 would be when it is more than 140, more than 90, according to the European Society of Cardiology, as we have seen up in the previous slides. There's a thing called mixed hypertension, when one pressure is higher and the other one is normal. And then, of course, there's isolated systolic hypertension when the upper reading of blood pressure is greater than 130, or the diastolic remains normal, less than 80, or isolated diastolic blood pressure is also hypertension when the systolic is consistently less than 130, whereas the diastolic is consistently greater than 80. I will not dwell heavily on causes of secondary hypertension. One, because secondary hypertensions are rare, but we have to be mindful that there are certain drugs, including over-the-counter agents, pain-relieving drugs, antidepressants, and steroids, and more particularly illicit substances. There are primary kidney diseases that may cause hypertension, and there are a number of hormonal abnormalities associated with hypertension. And let me just say that sleep abnormalities characterized by blockage of the airways, obstructive sleep apnea, common in people with weight problems, will tend to also trigger hypertension, as would be kinking of blood vessels from the main pipe, the aorta, called coarctation of the aorta, or kinking of the supply of blood to the kidneys, renal artery stenosis. The genetics of hypertension are particularly interesting, but this forum may not be give us enough time to talk about it. But it is worthwhile saying that essential hypertension, not because we need it, but that's primary hypertension whose cause is unclear. It's a common disorder with multiple genes and gene-environment interaction. We need to know that. Now, Peter Doris posited in his work on hypertension genetics the common disease, common variant hypothesis, in which he proposes that there is enough evidence that the recent, and mark you, this is not really recent, 200,000 years ago, there was an African origin and replacement hypothesis that people who came from the African continent as the cradle of humanity probably had a genetic variation in which there is a DNA mutation in the non-recombining region of the Y chromosome. This is the male chromosome. But whether this theory works and holds true is debatable, because by that hypothesis, the origin of all human beings would be in Africa. There are others who have said there could be disease susceptibility that arose independently in various other dispersed communities. And therefore, it's not clear whether we can say that modern human beings emerged in Africa and completely replaced or overrun other humans, or whether it was a product of multi-regional evolution occurring among a wide range of human species distributed even in the old world. Whatever the reasoning, we probably won't have enough time for that discourse. This slide shows the behavior of blood pressure with southwest gradient, herein represented by populations of West African origin, Nigeria, and rural Cameroon, that as they moved westwards in the transatlantic trade to the West Indies and to the United States, presented here by Maywood, not only did body mass indices increase, but the prevalence of hypertension went up to nearly a third of the individuals. Now, we have to remember that hypertension is indeed a key determinant of cardiovascular risk, including thickening of the muscles of the heart, myocardial hypertrophy, damage to the heart muscle, which is an infarction, heart attacks, or heart failure, or bleeding or clotting strokes, and kidney damage. And people of African ancestry bear disproportionately high risks of serious complications of hypertension. It is not clear whether there are susceptibility genes that influence not only inheritance of hypertension, but also susceptibility to the side effects or manifestations or complications of hypertension. You'll be familiar perhaps with the Kenyan Luo migration study done many, many years ago by Neil Poulter and his team. In the 1990s, they worked in a Siaya district, which some of you will know in Western Kenya, a community of Luo with about 35 villages and a total of 29,000 inhabitants. The interesting question was, could they demonstrate the magnitude, timing, and cause of changes in blood pressure that occur in migrants who left Western Kenya and went to Nairobi? And over several weeks, they had a total of over 2,000 Kenyan Luo, and the main outcome finding is all I will summarize. That systolic and diastolic blood pressures correlated positively with causal urinary sodium and potassium ratio. I'm glad the chairman is a physiologist and he would understand this better than I could, and negatively with potassium creatinine ratio. But the bottom line and the take-home message is that reducing dietary intake of salt, sodium chloride, by 50%, that's about 5 grams, to less than 5 grams may lead to a substantial blood pressure reduction. Similarly, increasing intake of potassium, which is a plant salt found in fruits and vegetables and juices, trebling your intake of potassium may lead to a drop in hypertension. Now, this slide shows the Mendelian forms, very, very heritable genetic forms of hypertension, and we will not have time to go into this. Now, is there a common thread between diabetes type 2 and essential hypertension? Let us recite that insulin is an ancient peptide with acute actions on certain metabolites like sugar, like amino acids and fats, and also chronic actions on tissue growth and differentiation. But it is a potentially lethal hormone by virtue of its tight and rapid control of glucose. It's also unique in the sense that it has no central regulation, unlike other hormones. And it is basically antagonized by a counter system of hormones, and that include growth hormone and catecholamines, thyroid hormones, sex hormones, and so forth. Now, insulin resistance must then be seen as an evolutionary process to blunt the acute effects of hyperinsulinism, which is excessive amounts of insulin. And insulin resistance therefore results when a given concentration of insulin is associated with a subnormal glucose response. In other words, inability to put away, tuck away a certain amount of glucose for that level of insulin to the fat cells and to the muscle cells, the main target of peripheral insulin action. Insulin resistance also features in a syndrome that was proposed in the 1988 Banting lecture by Gerald Raven, in which he put insulin resistance, abnormalities of sugar, hypertension, obesity, mainly central obesity, and abnormalities of fats, among other abnormalities, as components of the metabolic syndrome. Here we see that there are also effects on the vessels and on pumps, and that in the case of pumps, there is a significant impact where, for instance, the sodium hydrogen system may result in excessive retention of sodium and therefore promoting hypertension. If we can then step back and look now at diabetes, by definition, this is a chronic, progressive, and incompletely understood metabolic disease, and characterized by the presence of high blood glucose, or sugar as we call it, but that sugar refers to glucose. There's variable resistance to some actions of insulin, and there's inadequate secretion of insulin for a given metabolic state. And we have talked about associated cardiovascular disorders, as we saw. The International Diabetes Federation characterizes the Africa region as composed of 49 sub-Saharan African countries. Among them, Seychelles, which is a high-income country, but it also has some of the world's poorest countries like Burundi and Malawi, and countries characterized by very rapid economic growth. But I can tell you that this is precarious in some settings. Cote d'Ivoire, Togo, Ethiopia. But it suffices to say that some of the most populous countries in Africa account for nearly half of all adults between 20 and 79 years of age with diabetes in the Africa region. That 70% or more of diabetics are unaware of their condition, with the highest prevalence being in the mid-50s, 55 to 64. And sadly, diabetes accounted for 77%, more than 3/4 of death occurring before the age of 60. And those are dire statistics. I'll just flash this to show the clustering of cardiovascular factors in diabetes in my work for the doctorate of medicine, which the chair probably skipped to mention. But I looked at macrovascular complications in adult diabetics. And what is shown in this slide is the clustering, that nearly 90% of the individuals were obese, or 80% were hypertensive, and nearly 80% did not participate in adequate physical activity as defined in the research, and there were variable abnormalities in cholesterol. I will refer to this slide as perhaps the hallmark of my presentation. Aretias of Cappadocia, somewhere between 130 and 140 BC, was easily recognized as one of the most celebrated ancient Greek physicians. Cappadocia, as some of you may know, was a Roman province in Asia Minor, modern Turkey. I will read word per word because Aretias summarized everything that I'm about to say. That he described the characteristic muscle catabolism of diabetes mellitus as a melting down of flesh and limbs into urine. He recognized the common clinical features of the disease, namely the excessive thirst, the excessive drinking of water, the excessive passing of urine, which he described as incessant, as if coming from the openings of aqueducts. The nature of the disease, he said, was chronic. It took a long time to form, but the patient is short-lived if the constitution of the disease be completely established. For the melting is rapid and death speedy. Moreover, life is disgusting and painful, thirst unquenchable, excessive drinking, which however is disproportionate to the large quantity of urine. For the more urine is passed, the more one cannot stop them from either drinking or making water. Or if for a time they abstain from drinking, their mouths become parched and their bodies dry. The viscera seem as if scorched up. They are affected with nausea, sense of wanting to vomit, restlessness, and a burning thirst. And at no distance, they expire. That's the tragedy of diabetes, which I can only say is indeed a sweet life with a bitter end. Because it is diabetes that is responsible for 2 to 3-fold increase in circulatory death. It is also diabetes that is the leading cause of new cases of end-stage kidney failure. Similarly, it is diabetes that leads to blindness, and 50% of amputations or the cutting of limbs across theaters in the world from non-traumatic causes is related to diabetes. Now, it would seem ironic that glucose, our life sustenance, is also our poison. In this particular slide, Elizabeth Selvin looked at over 11,000 non-diabetic adults in a community-based population, with the question of whether the measure of glucose control that looks back for 8 to 12 weeks was associated with the risk of diabetes, or was it more strongly associated with the risk of cardiovascular disease and death from any cause? And here we can see that the ideal blood sugar by HbA1c would be between 5 and less than 5.5 to give you a parity relative risk of coronary events. And as the sugar goes higher, so does the risk, by 23% when the sugar is just less than 6, and by almost 80% when the sugar is less than 6.5. By American Diabetes Association, this is still not diabetes. But when it gets greater than 6.5, that is probably diabetes, and therefore the risk nearly doubles of a cardiovascular event. I want to flash a slide by Margaret Onen, in which she looked at the impact of social constraints on glucose control in adult diabetics in Botswana. It's an old study, but what is critical is that when one totaled the social support adverse score using the sum of what she used as a Norbeck social support questionnaire in diabetic individuals, it turns out that this was indeed a very sensitive indicator. A strong and direct correlation existed between adverse events and glycated hemoglobin. Importantly, the odds were highest for adverse score in those who were single, unemployed, uneducated, and had many dependents. But Ralph DiFronzo, one of the gurus in diabetology, says there might be a need for change in paradigm. Let us treat the patient, not the sugar. Let us reduce cardiovascular risk, not only the HbA1c. And here is a slide that applies the multifactorial risk concept done in Sweden, in which if you look at various risk factors, including age, being a male, total cholesterol greater than 5, systolic blood pressure more than 140, and smoking, compared to a reference population who are non-diabetic, younger than 55, female, total cholesterol less than 4.5, systolic pressure less than 140, and they don't smoke, the diabetic will still have a disproportionate risk based on their levels of blood sugar, as we have already seen in the previous slide. And as more factors emerge, so does the risk or increased risk of cardiovascular events. Here is another slide where we can basically say that the high risk of adverse cardiovascular events is disproportionate in diabetics, that most type 2 diabetics may ultimately die from cardiovascular cause. In the left-hand panel, Steve Hafner looked at about 1,300 non-diabetic subjects compared to about 1,000 diabetic patients in Finland. The risk of heart attacks was about 3 times compared to those who did not have diabetes. On the right-hand panel, this was a study by Jeremiah Stamler in the multiple risk factor intervention trial. Jeremiah and his colleagues looked at a huge number, nearly 350,000 men, screened for various risk factors that included cholesterol greater than 5, systolic blood pressure greater than 120, and smoking over a 12-year period. And what is clear is that the risk of death increases more steeply in the diabetic population, herein represented in blue, compared to non-diabetic. More strikingly, a diabetic with one cardiovascular risk factor mentioned above is nearly 5 times at the relative risk of death from a cardiovascular cause compared to a non-diabetic with 3 risk factors. In this slide, the same group of investigators demonstrate the impact of diabetes on cholesterol level, that a diabetic has a greater risk of death at the lowest cholesterol, total 4.7 or less, compared to somebody who is non-diabetic with a cholesterol of 7.5, 7.3 or higher. In the Interheart study, our analysis of the Africa Interheart component demonstrated hypertension, diabetes, smoking, abdominal obesity, and various abnormalities of cholesterol as accounting for nearly 90% of population attributable risks. A similar relationship was seen in other studies in other parts of the Interheart study that had 52 countries participating. If we categorize risk in diabetes, a diabetic would be considered at very high risk when they have diabetes and established cardiovascular disease. That would be either a coronary artery disease, other arterial disease, abnormalities in urine, kidney failure, or they would have target organ damage when they spill disproportionate amount of protein in the urine called microalbuminuria or macroalbuminuria. Or they would have major risk factors, herein represented by hypertension, dyslipidemia, smoking, and obesity. Or if they have type 1 diabetes, they should have had it for more than 20 years. A high risk, on the other hand, is a diabetic with a duration of disease greater than 10 years, but without target organ damage, plus any other additional risk factor. And moderate if the diabetic is type 1 younger than 35 or type 2 younger than 50 with diabetes duration less than 10 years. But I want you to know that lower is not necessarily better. In this study by Nielsen, lowering blood pressure excessively, represented here by the red line for systolic blood pressure in people with diabetes and hypertension, was associated with a higher relative risk of death or non-fatal coronary heart disease. That the ideal blood pressure for the diabetic might very well be about 130 or up, depending on the age of the individual. Now, others have basically been provoked to re-examine the question, is type 2 diabetes really a cardiovascular risk equivalent? And in this prospective cohort study of about 1.5 million adults aged 30 to 90, median follow-up for 9 years, almost 10 years, Rana and her colleagues in the Kaiser Permanente in Northern California, an integrated healthcare delivery system, tried to address that question. Of interest is that the outcome in diabetics was actually lower by 12.2 versus 22, challenging the notion. And they went on to say that type 2 diabetes and prior cardiovascular disease like coronary heart disease in non-diabetic patients are not necessarily risk equivalents for future events. Their conclusion was a recommendation that not all individuals with type 2 diabetes should be unconditionally assumed to be at risk equivalent of non-diabetic persons with prior MI. A more recent study looked at the residual risk, what remains after you have controlled everything that the diabetic may have. And for lack of time, I will brush through this because this is a recent study which was retrospective using data from the English practices. They had about 110,000 diabetics versus about 378 non-diabetics in the clinical practice research data link, together with about 330,000 diabetics from the Scottish Diabetics Registry. the fact is that even when all risk factors in diabetics are controlled, there is a residual risk of 21%. In this particular slide, Roshane and others demonstrated the long-term trends in excess risk of death and cardiovascular outcomes in both types of diabetes. Going through the type 1 diabetic, you will see that over the years from the late 90s to 2014, the duration of that study, death from any cause, death from cardiovascular disease, death from coronary heart disease, and hospitalization for cardiovascular disease tended to go down across both non-diabetic controls as well as in type 1 diabetics and also in type 2 diabetics. The difference is that perhaps if you had to extrapolate these curves to the COVID time, the figure would be very different. Now, I want to mention that part of the issue is that in those studies, reduction in mortality might have reflected the elevated or improved standard of care, interventions, new drugs. Now, there are drugs that are currently advocated, and I've just given them as examples without necessarily an endorsement of the drug mentioned. And that a level 1 class would be evidence or general agreement that a given treatment or procedure is beneficial, useful, and effective, and is therefore indicated. And a level 2 in the next slide, as we will see, is a conflicting evidence and or a divergence of opinion about the usefulness or efficacy of a given treatment. And it may be 2A that should be considered, 2B may be considered. The new classes of drugs that have changed cardiovascular outcomes belong to a group of drugs called the sodium glucose transporter 2 inhibitors, the gliflozins. I will not go for EMPA, DAPA, canagliflozin, but this is a class 1A recommendation. And also the glucose, the glucagon-like peptide 1 receptor agonist, the glutides. These are gliflozins, these are glutides. So liraglutide, semaglutide, dulaglutide. That they are recommended in patients with type 2 diabetes and cardiovascular disease or at very high risk or high risk to reduce cardiovascular events. And in particular, empagliflozin and liraglutide are recommended in patients with type 2 diabetes with cardiovascular risk or at very high risk or high risk to reduce the risk of death. And I think it needs to be emphasized given the disproportionate mortality rate in diabetics of death. Whereas the more common drugs like the metformin is a class 2A level C, and insulin may be considered in patients presenting with acute coronary syndrome whose sugars are very high. And therefore, we commonly use drugs that do not necessarily have a substantial cardiovascular benefit, returning to the previous slide. Now, I want to just blend this talk with a proverb in actually having recognized most of us from that region, that lak liech pepek kirode. This is a picture of an elephant I took in northern Botswana. That the tusks of an elephant are never too heavy for the owner could not be uniformly true for diabetics because age is a runaway factor. Can't control that. Gender is a given, and ethnicity is a given. Socioeconomic status and particularly socioeconomic deprivation is a problem. And in certain settings, religious faith might influence care for diabetes. And even when we talk of affordability, that may not even be available. The targeted treatment we have talked about that alter cardiovascular outcome may not be provided. Monitoring may not be possible. And the so-called healthy lifestyles may not be possible. And therefore, we need just to be careful when we say it's a given. And as I said in this particular picture, be careful with what you put in your mouth. Now let's talk about COVID. And the question about COVID is really the substance of this presentation. the COVID pandemic has raised many questions about the impact of comorbidities, particularly hypertension and diabetes, being the most prevalent conditions. Do patients with hypertension and diabetes exhibit greater susceptibility to COVID or severity of disease or outcome, in this case, death? And do these factors work as independent predictors of severity, or are they synergistic? I'm citing a study by Esmail Mehrahin. This is from Iran, of interest. But with his colleagues, they looked at the predictors of mortality in patients with COVID, a systematic review involving 114 studies. At the end, they were well over 300,000 patients from various parts of the world. They defined high mortality as greater than 10% in lab-confirmed COVID-19 cases. And the main predictors of high mortality was older age, hypertension, and diabetes. But it did appear like diabetes had an independent relationship. A more recent study by Naomi Holman from the UK asked the question, are there other risk factors associated with COVID-related mortality in type 1 and type 2 diabetics? A population-based study in England. They looked at weekly death registration in the first 19 weeks of 2020 when COVID had started, and compared a 3-year weekly average between 2017 and 2019. And COVID-related mortality was defined by ICD-10, an international classification of disease version 10, using this code U07.1 and U07.2, and whether that death was, whether COVID was the primary cause of death or the secondary cause of death. And here we see the hazard ratio. The confidence interval has been concealed for lack of time, but the fact is that in both type 1 and type 2 diabetics, being a male increased your risk of death from COVID if you're diabetic by nearly 60%. We don't know the reason. Being over the age of 70 by 89, let's say 90% or higher, even 4 times if you're over 80. And severe socioeconomic deprivation by about 90% in type 1, and I can only presume that the demands of self-care in type 1 diabetics far exceeds those in type 2, and about 63%. I'm probably lost. Now, being a Black, again, not a choice, risk is 70% or higher, or 60% with type 2 of death. If you compare this to the Asians, where that is about 57% or even just 8% in type 2 diabetics. Poor control of the blood glucose doubles the risk of death from COVID if your sugar is greater than 10% HbA1c. And therefore, high blood sugar matters. Kidney failure matters. If the kidney can only clean less than 45 milliliters of blood, that risk is more than double, and it's about 80% higher in type 2 diabetics, and gets worse with progressive chronic kidney disease. Regarding weight, in fact, BMI greater than 35 increased the risk in type 1 diabetics and not so much in type 2, but the relationship is U-shaped, such that if you are lean, less than 20 kilograms per meter squared, your hazard ratio of death was about more than 2.45 for type 1, 2.33 for type 2. But also if you are morbidly obese, BMI greater than 40, the risk is also doubled. And the ideal weight seems to be being overweight with a BMI of 25 to 29. Of interest is that systolic blood pressure greater than 140 appears to give some relative protection from death from COVID, and that seems rather paradoxical. The question is, are patients dying of COVID-19 or dying with COVID-19? And I'll leave this for a discussion. Because if you are using the ICD-10 with U07.2, the COVID virus is not identified. It is either probable COVID or suspected. Whereas the U07.1, the COVID virus is identified. So attribution of death to COVID may be tentative at best when this particular code is used. I want to highlight again that even weight or BMI is not universally a risk factor. Here in this study by Leiter, we see that age might influence mortality outcome, or rather admission or discharge from the emergency room. They had over 3,000 individuals, and being greater than 60 seems somewhat protection, even though obesity was a risk factor, whereas those who are younger than 60 had an elevated risk of being admitted to the intensive care unit. This particular slide may be sensitive in the sense of the use of minority ethnic groups. But what they are saying is that the minority ethnic groups are not necessarily to be seen as a homogeneous community, but the fact is that they have a greater burden of cardiometabolic disorders. They may have lower socioeconomic status, poorer diet, low physical activity, poor housing, which are overcrowded, multi-generational, and so forth. And that may be playing in the issue of the COVID outcome. But these researchers were not quite sure what else really explained what was going on. So I picked some highlights of poor COVID outcomes in minority ethnic groups. I'm appalled that 64% of COVID deaths among National Health Service staff occurred in minority ethnic groups, who make up only 20%. I need to be corrected, I may be wrong. But that Black ethnicity increased the risk of death by more than threefold compared to whites. And as I said, greater cardiometabolic burden in minority ethnic groups, especially the males, and that the role of obesity should be taken into account, as well as socioeconomic deprivation. But also importantly, attitudes might matter, because negative attitudes to self-care for chronic diseases or the COVID measures might compromise outcomes. If I may conclude, and I know I've gone beyond time, that several factors are associated with severe COVID and related death. Some are modifiable, some are non-modifiable. And that hypertension and diabetes are major cardiovascular risk factors in their own right. And they compound the outcome in diabetes, in COVID. That in conclusion too, that we are seeing a deadly overlap between COVID and chronic diseases, namely hypertension and diabetes, leading to a crisis of priorities for health systems already struggling with inadequate resources. That low community and awareness and social and ethnic inequalities may make the task of cardiovascular disease prevention and COVID control more complex. And that control and preventive measures require innovation, new resources, unprecedented levels of cooperation among multilateral agencies, national authorities, communities, the private sector, and other stakeholders, based not only on rigorous science, but also on a clear ethical vision. And that the guiding principles for global health should conform to the WHO, the new public health, and the ethics of the 21st century, in which WHO proposes enjoyment of the highest attainable standard of health as a right, a fundamental right of every human being without distinction of race, religion, political, economic, or social conditions. And the new public health seeks improvement in health best attained by behavior change, and environmental change by focusing on the broader influences of environmental factors and physical, social, and psychological elements, as well as healthy lifestyles. And the ethics of the 21st century embraces the amalgamation of individual bioethical issues, individual health, and human rights in the broader arena of public health, guided by the principles of equity. And if the chairman introduced my photographic skills in his introduction, I think I leave you to judge for yourself about my being an ardent photographer. This was a picture I took from the back of an audience in a cardiology conference in Dubai. But suffice it to say that hypertension and diabetes are more than a double whammy in COVID times. Thank you very much.